Be ready. Welcome to the show, Dr. Kahn. Thank you so much for being here.
It's my pleasure from cold Detroit, Michigan.
Yes, to Atlanta where it's nice and warm. At least we're on the same time zone though, right?
It makes it easy. I
That-
agree. I
that's
like going straight down or straight up, but no
Yeah,
sleep disruption, right?
I love it. Well, I am so happy to have you on here as an expert in all things heart health. One of the things we've talked about a lot on the podcast is that cardiovascular disease is still the leading cause of death in the United States. And so I wanted to hear from your perspective, how much do you feel like genetics play a role versus lifestyle when it comes to heart disease?
Yeah, in my clinic, I have a sort of an advanced heart clinic in Detroit. We drain every drop of blood from every patient. Basically, they get a lot of labs, and some of the labs are genetic analysis, and some of them are the typical blood sugar, blood cholesterol analysis, and a lot of questions about family history and lifestyle. So I think I'm pretty good at actually trying to determine in a patient between that split. The literature, meaning published studies, might say between 8% is genetic all the way up to about 30% is genetic. It all depends how many tests you do. And when you start doing more testing, you'll find more genetic underlying causes. And of course, if somebody says, yeah, grandpa had a heart attack at age 46 and my dad had bypass at age 51 and mom had a stroke at age, 38 or something, there are families like that. You're obviously going to hunt a little harder for a genetic cause. And if everybody's 95 years old, you'll hunt a little less. But when you ask me, I'd say about 25%.
Which I think is very empowering, though, because there is, in that case, 75% of things we can influence with our lifestyle. And that's one of the big reasons I love talking about cardiovascular health, is because there is some things we can do to improve our heart health. And I wanted to hear, like, what are some of the lifestyle variables you see have the biggest impact in cardiovascular health in your practice?
Right. And just to go back for a second, then I'll come back. Some of the genetic influences are also able to be manipulated. For example, you're familiar with methylation, MTHFR defects. I just emailed a patient this morning. His homocysteine was like a world record in my clinic. That's genetic, but we'll bring it down with a high dose B complex vitamin program so we can fix it. Lipoprotein little a, my favorite cholesterol particle in the world, hopefully we'll talk about, is purely genetic. We'll have drugs that'll lower it starting in 2025, 2026. But even now, there are ways to manipulate it, even though we can't, turn the gene off as far as we know. So anyways, we're never without hope or never without a plan. In terms of lifestyle, I mean, the history would be go back to the 1960s. The word risk factor was developed because of something called the Framingham Heart Study outside of Boston. And we learned 5 things. Do you smoke? Do you have diabetes? I would now include pre-diabetes, a elevated blood sugar that doesn't quite make diabetic goals. Do you have high blood pressure on treatment for it? Do you have high cholesterol? And I would throw in that lipoprotein little a, and you have to test for it or you'll never know. And finally, do you have that mom, dad, brother, sister, grandparents, aunts, uncles with the early heart attack, stroke, sudden death, drop dead profile? That was the big 5 we learned in the 1960s. Now we can add, you said specifically lifestyle. So sedentary lifestyle, that's a problem, sitting all day long. And a lot of jobs require that. If you're driving an Uber, you're not getting much activity. You're not getting many steps. We know that sleep apnea, undiagnosed, untreated, is a big deal. We know that lifestyle, if you include your health of your gums and frequency of your dental visits and maybe old silver fillings from when you were a kid, leaching mercury, maybe not. That's a little in between. That's lifestyle. Highly processed food diet. We didn't talk about that in the 1960s. There wasn't so much of that, but 60, 70% of calories, people are rushing around and letting somebody else make their food that doesn't care much about their health. That's a lifestyle risk factor. Home cooking may be the best step you can do for your health in every regard. Of course, not if you're using a deep fryer for every meal, but home simple cooking. I'm a plant-based guy, so home plant-based cooking would be, to me, the optimal goal. Um, you know, We don't think of psoriasis as a lifestyle, although it does respond to improved diet and other measures. And psoriasis is related to heart disease, as is lupus, as is rheumatoid arthritis, as is polycystic ovarian kidney disease, as is gestational diabetes and hypertension of pregnancy. So we spend a lot of time with women asking about some of their earlier history with those things. So yeah, and then menopause. Menopause isn't a lifestyle option. It's part of aging, but we can intercede with the drop in hormones and maybe replace them, because heart disease goes way up in women after menopause. So these are all things that can be what's been called non-modifiable risk factors and modifiable risk factors. The one we can't do much about is your age. There's no doubt disease becomes more common with age, but most everything else we can, intercede upon.
How much do you feel like stress plays a role in what you see with heart disease?
Yeah, stress is often appropriately called like the elephant in the room, the thing you might not even bring up. Although I ask every patient about stress and where it's come from, what they do for it. If the solution to stress is a pack of cigarettes a day, because that's your friend. If the solution is, a pack of mini donuts, because that's your friend, or a fifth of Mohawk vodka, if your solution to stress is I'm going for a walk, I'm going to get on the treadmill, I'll do some weights, you've moved it in the positive realm. There's no doubt we've had 70 years of data. Herbert Benson, a Harvard professor, made stress and heart disease a popular topic. Dr. Dean Ornish, one of the kings of lifestyle medicine, made yoga, meditation, stress reduction a proven therapy for heart patients as one approach. And I do herbal stuff, ashwagandha, theanine approach too, whatever it takes. But, bringing it up, trying to reorganize your life, trying to deal with it. Good night's sleep, one of the best therapies for stress. It's a big factor. And it's not just that it leads to suboptimal lifestyle choices like donuts. It's also directly may cause our arteries to constrict. There's multiple studies. If I were to give you a complex math problem and I had a way to measure the health of your arteries, there actually is a temporary reduction in the health of your arteries, or if I made you give a public speech, for example. So stress can have a temporary and a long-term detriment to the heart. Now, a lot of us thrive on stress. I like to be busy, but I've turned it into a positive factor.
That you stress. Well, and I think they used to say, smoking is the worst thing we could do for our health. Then it was the sedentary is the new smoking. And then now it's that loneliness is the new smoking. And it's like, how much is that playing a role? And you mentioned so many things that I wanted to touch on, but one of the ones I want to get your thoughts, because I know you're in the research from a cardiovascular standpoint, is the microplastics. Are you feeling like that's playing a big role in cardiovascular disease?
Right now, as we talk, when you have a factor, but you can't measure it, it's worth conversation, but it's not going to become an easily identifiable problem. That's the problem with microplastics. I think I just saw somebody's offering an expensive urine test and measure the concentration of your microplastics. And you can do that for BPA and BPS and DDT, and you can do it, although it's not a microplastic, for glyphosates that you might be getting from non-organic foods, although you probably get a little from organic food. So you can do these things. These are advanced. You're not going to find them available in most practices, and they're certainly usually not covered by insurance. So there's all kinds of impediments. As far as we know, there's really mainly one study that if you have a patient that has to go for a carotid surgery and they literally scoop the plaque out and then clean the artery out and sew it back up, there will be microplastics in the plaque. Did it cause the plaque? Is it maybe there's microplastics throughout our body? Because we also know now you can find them in the brain, in the testes, in the penis, God forbid. Haven't seen a study on ovaries. I'm sure it's probably everywhere. So yeah, we're learning, but it's a tough one. I mean, I hate lecturing to a medical group and I see a plastic water bottle. I better put mine aside in front of everybody, but I'm hoping that this popular drink is a BPA-free plastic bottle. I never really thought about it before, but you'll never see me with the typical, water bottle that everybody uses and throws away. It's bad for us. It's bad for the environment. Drinking hot coffee in styrofoam cups, bringing your lunch every day in plastic containers, microwaving in plastic. Oh my God. Taking a hot dish and put saran wrap on top and watching it melt into it. And then, fast food is horrible, but the wrapping of fast food leaches plastics, microplastics into our food. The wrapping may be as bad as the food by the end of the day. That's just, you can run, you can't hide, but there's lots you can do.
And every little by little, a little becomes a lot. So those small changes, bringing glass for lunch and, it adds up over time. And I also wanted to go back because you were talking about menopause, and this is something we talk a lot about in functional medicine is hormone optimization. And I feel like in the cardiology space, it's still very controversial of hormone replacement therapy or not. And it sounded like you were kind of alluding to that you're pro hormone replacement therapy in perimenopause and menopause. And is that because of the estrogen and the endothelial lining and like the research there?
My own, clinical observation of my patients is the women on bioidentical hormone replacement therapy are happy. They sleep well, their weight's controlled, they're vibrant, they're sexual. Their cholesterol doesn't rise as much. Their lipoprotein A doesn't rise as much. If they inherited the ability, they sleep better. I see that in my own family, but in many, many patients. So I've read the literature. There's a nice little triad, a gynecologist in Irvine, California named Felice Gersh, pretty well published, MD, and two cardiologists, Dr. Carl Lavey and Dr. James O'Keefe. They're both friends of mine, nationally known cardiologists. And they've been publishing as, integrative gynecologists with two cardiologists of premier standing that, we need to rethink this, that there's probably cardiovascular protection. There's advantages for brain health, bone health, and properly done, it should be considered in women as they enter menopause.
And I think that's what's been really exciting is I feel like for me in the research I've looked at, women were often excluded from research studies. And it's like, this feels like a big time in science where women are being studied, looking at the role of estrogen in brain health. And also from our understanding is there is a big difference between taking an oral estrogen and a topical estrogen when it comes to the liver and clotting factors. And so are you a proponent of topical estrogen and things like that as well?
Nobody should be taking oral estrogen. That's a red flag. You're dealing with a practitioner that needs to be rethought, right? It should be a patch or a compounded topical cream. You can take your progesterone orally, but not your estrogen. I agree.
I'm glad we're on the same page. And then I want to talk about the diet a little bit more because I think this is the thing our patients always come in and they're so confused about. And I think the hard thing is you can almost find a research study for every diet, right? And I think this is where you kind of are picking, like, is it the heart we're protecting? Is it the gut we're looking at? Is it the brain we're looking at? And I know you're plant-based, so you might have a very, strong opinion on this, but do you feel like there is one diet that is best for everyone, or do you believe in this individualized approach, or like, how do you tackle nutrition in your practice?
Yeah. So I started plant-based 48 years ago to survive the worst dormitory food in the world. That's a true story. But I stayed plant-based because of the science. And I started reading a few years into it as I entered medical school and residency and fellowship. And, then research like Dr. Dean Ornish, premier lifestyle medicine doctor, about reversing heart disease with plant-based diets, and many others are, putting type 2 diabetes into remission and reversing rheumatoid arthritis and lupus. And there's plenty of, actually published studies. Now there's reversing early dementia with plant-based diets. And there's data now growing like crazy for bladder cancer, prostate cancer, urologic health, renal preservation. So, I don't agree that there's a study for everything, actually, even though you're very well read, because the very popular ketogenic diet, there's not a paper in the world that can reverse or stabilize cardiovascular disease. In fact, there's concerning literature that some people get crazy cholesterol levels and it may trigger a cardiac event. There's very little literature in general, but there's no favorable. Same with the carnivore diet. Mediterranean diet, which is a grab bag for a cleaner diet than the average American. There are definitions of it, but I think people, I do the Mediterranean diet with bacon. No, that's not the Mediterranean. There is no med bacon diet. Sorry, you're just eating sloppy. But the plant-based diet literature is enormous. It's enormous. I write newsletters for doctors, and I have my own podcast, and I educate my patients every week with what's new in the literature. So I'm really a literature freak. I love reading what's new, and I mean I got Google alerts for carnivore and keto and paleo, and they just are lonely little alerts for what's new. So, but to answer your last question, I don't think anybody knows. If we had 1,000 people and put them on a whole food plant-based diet, we provided the meals, great looking, tasty, fresh meals of fruits, vegetables, whole grains, and legumes. And then we shifted them to a really well done keto diet, and we shifted them to really well done. How many people would rate their wellness and look at their biomarkers and their gut bloating and their stool frequency? I don't know. I mean, my wife and I, and so many of my patients have done so well, never touching an animal product for years and years and years. It's sustainable, and it may be the best environmental, and it's obviously the nicest animal rights approach to kindness. There's no question about that. But, is there somebody? I listen to my patients. Doc, I felt better when I added back salmon. I felt better when I had chicken once a week. I mean, I'm not going to yell at them and say, no, you didn't. You didn't feel better. You bought the purple Kool-Aid. But I don't know why a few people, is it their type O blood? I don't really buy into the blood type diet approach. Or is it, I'm blood type A, so I'm predestined to be a plant-based guy. Maybe there's some truth to that. I don't know. I think it's controversial. I think everybody should try a month of whole food plant-based diets, and they may be surprised. The bloating and the gas and the acne and the skin rash, a lot of things quickly go away.
Well, and I think also the hard thing is the quality of our meat in the United States is really bad too. So I think that also plays a role, and even our fish quality. When I was referring to some of the research, is not even around cardiovascular health, but it's you'll see a study on keto for epilepsy, or, things like this, where it's okay, maybe there is a health benefit of this, but the hard part is, and what I find, let's say, for example, you are epileptic and they recommend a keto diet. We know that's going to compromise your gut flora because you're dropping your fiber, right? And so it's I think the common denominator that both of us say is we need a plant dominant diet. I think no matter what you look at, we need a ton of plants. And I look at meat, with my patients, as an accent. It should not be the main attraction of every meal, making sure we're getting lots of diversity and color and things like that. Because I think the problem when I talk with my patients is the serving of vegetables that they think is what they need is 2 broccoli on the side of their plate, right? And they're getting vegetables. And, I'm no, we need 6+ big cups of vegetables minimum. And so, I try to get my patients to do 1 huge smoothie, 1 huge salad, getting a lot of that plant diversity. And you probably saw the study that the people that live the longest ate 30 different plants per week, which is exactly what, you're preaching and we believe in so much. I was vegan for 9 years and teaching fitness classes, running marathons. And there did get a point where I just never felt satisfied. I was hungry all the time. I felt like there was something off. And it was probably at the time my knowledge base in it. But that I was probably your patient that you're referring to. That's I feel good with meat once or twice a week and then eating very plant-based. And so it is kind of interesting. And I also am in line with you as what is that difference? We have a lot of people that feel great plant-based and we have some that are kind of in between. But I think the common denominator for all of our listeners is we need to eat more plants. I think everybody needs to eat more plants. And so hopefully that message is clear.
I think the current, debate so often on social media sites is the protein debate. And I mean, it's overwhelmingly clear we are a fiber deficient US population. We're very rarely a protein deficient US population, because you can do that easily with plant-based foods and obviously with animal-based foods. But fiber, you can't get fiber in a T-bone or a chicken breast. So, you want a good gut, you better be pounding down those 30 veggies and fruits and veggies, those colorful foods you talked about.
And people think like when I tell them that, their eyes get huge. Like, how am I going to get 30 different plants? And I'm like, it's all plants, right? This is pumpkin seeds and lentils and beans. And like when you really write out a list, you're like, it's not that hard to get 30 different plant-based ingredients. So I love that. The other thing I wanted to circle back on is the lipoprotein A. This is something we check on all of our patients, but I don't feel like our conventional cardiologists are checking an LP little a. Why is that? And kind of tell us, like, you love this marker too. I want to hear more of your perspective as a cardiologist.
Yeah. So, for those that don't know, lipoprotein little a, and I'm going to be a little commercial here. I'm the only guy in the world that's written a book on the topic. So there's the title, so you know the word, because it's an awkward word, lipoprotein, lowercase a, but we pronounce it lipoprotein little a or LP little a. It needs a new marketing name. It's also called the sticky cholesterol. If we had called it that, it would have been much easier. And it is simply just a checkbox on any lab slip, but it was discovered back in 1963. So we've had, 60 plus years of research, thousands of studies, that 20% of people have a liver that their parents gave them a gift. Their liver can make that cholesterol. It's not such a good gift, but it's a gift. 80% of people will never make lipoprotein A. And I think we'd like to turn it off so you never could make it, but 20% of people don't have that option yet. 5, 10 years down the road, gene editing, we may be able to turn off. And it's a simple blood test. 20% of people fall in the normal range. Excuse me, 80% of people. 20% of people can be a little high to unbelievably high. And we've learned that there's the potential, not the certainty, clogging arteries, causing inflammation in arteries and causing clotting in arteries. That's basically stroke, heart attack, and dying early. Plus, this particular cholesterol will clog one heart valve called the aortic valve, and there's a rather serious condition called aortic stenosis that can be completely because you inherited this cholesterol. So yes, I've been drawing on everybody for about 15 years, easily 10,000 plus patients, and 20 to 25% have it. Some have no disease. I check like crazy. And some are really in trouble at age 42. I've 33-year-old had a massive heart attack. He's doing very well now. It was entirely lipoprotein A. And also the reason cardiologists aren't drawing it is a nihilistic statement. Well, there's no drug approved for it. So why am I going to draw it? And, you might educate a patient, you're carrying a risk factor. It's even more important to get your fitness, get your sleep, monitor your weight, your blood pressure, your blood sugar, your inflammation, eat wisely for your heart, and maybe actually check your heart. And maybe we'll talk for 2 seconds. How do you check your heart? Number two, it's all going to change because of money. Money's the real answer because there is no drug. So there is no Little Caesars pizza lunch at the doctor's office to educate the doctors about this. But starting in 2025 and for the next 5, 10 years, we're going to get multitudes of brand new drugs, injectable drugs at first, later oral drugs, that are specifically geared to lower lipoprotein A. They're all in research studies now. The research results are looking very favorable. And the first major result may be available May of 2025. And whatever number of months it takes the FDA to approve the drug, it'll suddenly become available to sick heart patients, heart attack survivors, bypass survivors. So cardiologists will start drawing it. There'll be a new drug. There'll be Little Caesar pizza lunches. And it'll be bad for the cardiologists. They'll be eating worse food, but it'll be good for the patients. They'll get checked. I can lower lipoprotein A now in my clinic. There's all kinds of strategies, including that woman entering menopause who gets placed on hormone replacement therapy. It will come down. There's other strategies. The Lipitor, the Crestor statin drugs are useful for cholesterol. They're actually bad for lipoprotein A. They make it go up. So one of the first things I do is I rearrange the patient's medications, and voila, their level's much lower than it was when I met them. That's one approach. And there is a way to actually, if you're really, there's some people like the 33-year-old who had a bad heart attack. There is a way to filter lipoprotein A out of the blood, like you're a dialysis patient. It's called lipoprotein apheresis. It's approved by insurance companies. There's very few places in the United States. It's a little more popular in Europe. And that will end when we get these drugs. These drugs will be much easier and more beneficial. So that's
You do that at
lipoprotein.
your office?
What's that?
You do that at your office?
No, I don't think in my state of Michigan we have any place doing it. Perhaps University of Michigan. It's very expensive, very time consuming. There's risks like dialysis. You have to have catheters in your body for hours and hours. So a specialized cholesterol center at a university may offer it, but I don't see any need to refer people.
What is your thoughts on Repatha for high LP little a? Do you use Repatha?
Yeah, so Repatha is an injectable drug that every 2 weeks you give yourself a small shot. It's great at lowering regular cholesterol, LDL cholesterol. And when the drug was tested 9 years ago, and the FDA approved it, it was only approved to lower cholesterol, and usually only in people who could not tolerate Lipitor, Crestor kind of drugs, because they're much, much cheaper and easier to just pop a pill a day than take a shot. There's a lot of people can't tolerate those drugs. So it's largely the people that had heart attacks, strokes, bypasses, and stents. It was found during the studies that it did lower lipoprotein A on average about 25%. These new drugs lower lipoprotein A like 95%. So the new drugs are way more effective than Repatha. And the insurance companies don't care about your lipoprotein little a, because the FDA did not approve Repatha for lipoprotein little a. So you can't submit to get insurance to pay $700 a month just because you have a crazy high lipoprotein little a. Some people make up a reason that's not completely legit. Some people pay for it. That's a lot of money, $700 a month. And most people don't get Repatha. Furthermore, there isn't clear-cut, we call them outcome studies. We took people with a high lipoprotein A and proved they had less strokes, heart attacks, bypass, and stents. It probably is the case, but the studies are sketchy. And they will become irrelevant by next year when we have the super duper drugs.
Well, and also when it comes to LP little a, it's not going to show up on a CT calcium score, right? Like you can have a CT calcium score of 0 and really high LP little a.
You won't know. I would go the opposite. And you just mentioned my favorite study in the world. If you go for a CT calcium score and it's abnormal, I would definitely want to know what your blood lipoprotein A is. But lipoprotein A elevation will calcify heart arteries. So when I have a 42-year-old in the clinic with a lipoprotein A level of 300, I will probably order a carotid ultrasound called a CIMT, a little tricky to find, but very accurate. And I'll usually do the coronary artery calcium score for $100 and define, are they the subset with lipoprotein A that are getting impacted by it and developing hardening of the arteries, or are they so far free of disease, and then follow them long-term to see if their freedom of disease is changing for the worst over time. And we have now that advanced CT scan called the CT angiogram with artificial intelligence, often referred to as a Clearly Health CT angiogram. It's much more accurate, but it's 10 to 15 times the price. You have to inject iodine dye. And if you're free of disease, I usually don't move on to that more advanced test for a lot of reasons, including a little more radiation.
So you feel like if somebody is high in LP little a, but their CT calcium score is still 0, that they're still in the low risk, and you wouldn't probably do anything with that LP little a? Because we see that often in our patients, and it might be because we're a functional medicine practice. A lot of our patients are doing a lot of things for their health when they come in, but I see it all the time, this like high LP little a, family risk, and a CT calcium score of 0. And, it kind of feels like a disconnect when they have this like super high LP little a risk, but that, I guess, is your point of that is more genetic. Their liver is making it. It may not be causing disease at this moment.
Yeah, it's like we say to all the smokers, not every smoker gets lung cancer, and not every donut eater gets diabetes. Lipoprotein A is a risk factor. Maybe it doubles, maybe it triples the risk for clogged arteries, but it's not 100% certainty. I have 85-year-old patients with high lipoprotein A, and they have no disease in their vessels, and none of their grandparents or parents had that. You take family history like I do, it always makes me scratch my head. Wow, you have such a high lipoprotein A, but nobody in your family had that early cardiac scary event, and it came from somewhere. We don't think you just, de novo get lipoprotein little a. So it's very important, but it's not something you need to write your will out when you get your lab test back. You need to get tested, but you don't write your will out.
Well, and I wanted to kind of talk about the traditional LDL and like how a cardiologist may evaluate risk and look at that. Because I know when I have like certain cardiologists in town that I'll send to that don't kind of have this blanket statement that everybody that's mildly at risk needs an LDL less than 70, right? I feel like we've got the cardiologists that are telling my patients that, and then we've got the cardiologists that are kind of looking at the full picture. And there seems to be a big mismatch still in the cardiology space. And so I'm just kind of interested in your thoughts on traditional LDL, some other markers.
Right.
You have a blanket number. So talk about that.
Sure. And I'll make a quick commercial comment. I used to have an office in Alpharetta, and I've been licensed in Georgia for 10 years. I have a lot of Georgia patients, but now they either come to me or we do telemedicine. So I'm happy to help with anybody you know. Not that I'm deficient in patients. I have plenty of patients, but I love the lipoprotein A ones. But to answer your question, the kind of pivot I took years ago, there was a group that still exists called the SHAPE Society, Society of Heart Attack Prevention and Eradication. They developed a website. They published a textbook, a really good textbook on preventive cardiology, and several peer-reviewed papers. And they said, your typical patient in the family doctor office, 45-year-old, cholesterol's 265, LDL's 178. Maybe they're high sensitivity, C-reactive proteins up a little bit because they're eating crap or their waistline's big or they haven't been to the dentist or they snore at night. You know, the traditional approach is here's your lifelong prescription for Lipitor, and good luck, you don't get myalgia or a rise in blood sugar or a rise in your liver function studies, which are all relatively rare side effects, but they're definitely real. The SHAPE Society said, we don't just give chemo out to smokers. You know, we don't do that till we identify a cancer. Why don't we do a carotid intimal medial thickness test? Why don't we do a calcium score? This was 2007. And if you have no plaque, we're not going to recommend prescription therapy. We're going to stress lifestyle, maybe supplements, berberine, bergamot, Reggie's rice, niacin. And it took a while, and I adopted that, you know, long ago because it just resonated with me. So I will not treat people without plaque with prescription cholesterol drugs, with rare exception. You know, your cholesterol's in the 400s, we'll reconsider. And that's now actually endorsed since 2019 by all the societies. The American Heart Association says if you have a highish cholesterol panel and other risk factors, but you go for this vascular testing that comes out clean, you can opt not to take a prescription drug. That's a rather amazing statement in a guideline by the American Heart Association and the Canadian Heart Association, stodgy group called the National Lipid Association. Now, that's not what most primary care docs and most cardiologists will do. And I still struggle with it. So I've got to convince that patient, you've got to come back in 3-4 years. And we want to retest. And if your 0 calcium score is now 12, or if you're a clean carotid show plaque, we're intervening at a time that's still early. You know, the skeptics would say, well, they're all going to develop plaque, but it's true. It's not true. I mean, people with a bad risk factor profile should be concerned, but they're not doomed. So that's how I approach it. Now that we've introduced these advanced coronary CT angiograms, because even with a calcium score 0, there are some people with small amounts of what we call soft non-calcified plaque. It's some risk. You know, I'll present to them if their lipoprotein A is very high and their LDL is very high, but their routine vascular testing is clean. You know, if they're willing to put up $1,500 out of pocket and understand the risks, we'll do that advanced study. And sometimes it'll make me change my mind, but I still don't consider those tests, even though I've ordered 1,000 plus of those clearly CT angiograms, I still don't consider them routine. We can't even get doctors to order a $100 calcium score. There's no way we're getting the mass of the public tested with a $1,800 CT scan.
Well, and I feel like to me with cholesterol, like so many times their VLDL is super low, their HDL is good. You run a particle size. So you look at their small LDL particles, they're less than 90, their CRP is less than 1. You know, it's really hard. And I'm glad that you kind of look at it the same way, because I see, I know you're saying it's relatively rare, but I see a lot of my statin patients develop prediabetes. And I don't know if it's time and age, but I would say, I don't see as much of the myalgia or the muscle pain in the liver, but I feel like almost all of them, I'll watch their A1C, even if it's like 5.3 to 5.5 to 5.6, like, and so that's where we've really liked, and I am interested in your thoughts on this, a lot of the research on the GLP-1s, like microdosed for cardiovascular protection. I know that one study came out that saw a pretty good reduction that seemed almost better than statins with first cardiovascular episodes. Do you buy into some of that research? Like, what are your thoughts with GLP-1s?
Yeah. Yeah, the big study, it's called the SELECT study with GLP-1s in heart patients, and they showed, impressive reductions in outcome problems. So, I mean, it's on the map now that Ozempic, Wegovy, Mounjaro, Zepbound are cardiovascular drugs, but at $1,000 a month with a lot of constipation and nausea and, temporary benefit because the drug doesn't keep working when you stop the drug. It's not my first choice. I mean, I write them, but pretty infrequently. What I do routinely, and I suggest you consider it, I see people all the time come to me on medium to high dose statins, 40 milligram, 80 milligram. I drop them to often the lowest dose possible, and I add ezetimibe, 10 milligram. Nothing I thought of, a drug that's been FDA approved for over 20 years, costs $6 a month. And when you combine them, you get amazing cholesterol results. Interestingly, if they have lipoprotein A that's high, it'll usually drop because statins will raise lipoprotein A. And when I go from 80 to 10 milligrams of atorvastatin and add ezetimibe, I usually can get about the same total in LDL cholesterol, but lipoprotein A drops a lot. So the apolipoprotein B drops a lot because we're in better shape. And their hemoglobin A1C starts to come down. So I'm a microdose statin guy, but it has to be with this kicker called ezetimibe. And, Merck used to make that as one pill called Vytorin, but since these drugs are now generic, we just have to call them the two scripts. There's actually some data from Korea in a 3,000 patient prospective study that the combination of a statin and ezetimibe reduces plaque in heart arteries more than a statin alone at a higher dose. So there's even more incentive to do that. And, people push back and say, that's an old drug, ezetimibe, nobody uses it. That's ludicrous. It's really the routine 5 in 10 of ezetimibe or 10 in 10 ezetimibe in my practice. And the lab values are just spectacular.
Yeah, and less side effects than what I see too, which I think is nice. And we even have some patients that just need a little statin support. They'll take it every other day. I don't know if you ever do that. I know that's probably not a traditional way of doing it, but I'll be able to keep their cholesterol levels great. And they generally feel better because they start to get a little bit of the brain fog, which I'm also interested. This is a total side note. But do you think part of the reason menopausal women's cholesterol goes up is because it's the precursor of hormones and it's the adaptive pathway of trying to get them to have more hormones? Like, is it a physiological effect when they lose hormones that their cholesterol goes up?
I don't know if that's scientifically correct. It makes a lot of sense. I truly have never read a paper that proposes that, but sure, makes sense.
Because I'm like, cholesterol is the precursor of pregnenolone, so it's like your body's going to want more of that. So total side note that I just was thinking about. And then do you value particle size? Like, do you look at particle size or do you feel like it's really not that important?
Well, I do order it on everybody. It's just additional checkbox, and it's, maybe a $25, $30 blood test for a long time. I mean, I started ordering those 20 years ago when they were a little more exotic. And, the research says, but this is now relevant to most of America, that if you have a pre-diabetic or a diabetic or an obese patient, if you look at just the routine cholesterol panel and it comes back LDL 100 and look at an advanced cholesterol panel, LDL is 100, you'll find by doing the advanced test, the LDL particle number, you'll identify many more people with a adverse cholesterol profile by the advanced test than you will with the routine test, even though they both come back with LDL of 100, but one will have an LDL particle of 1900, one will have an LDL particle number of 1000. So since most of America is pre-diabetic, diabetic, or overweight or obese, we probably should be doing them, almost routinely. That's the data that's presented. Yeah, and again, if they have a calcium score of 0 and clean carotids, we're going to stress lifestyle, weight loss, exercise, whole food diets, get rid of junk. And if they've got disease, now I've just got to treat them more aggressively to try and get the particle number down, which is going to be lifestyle, but I may be incorporating more supplements or more prescription drugs.
Well, and the metabolic side is interesting on that because I do have patients that will even have an LDL of 90 and their small LDL particles are like 800. And to me, that's like never made sense. But I wonder if I go back and look at those patients, if they have borderline insulins or, A1Cs in the pre-diabetic range. So, we know metabolic disease is a big driver of cardiovascular disease. But do you see the small LDL particles are more driven by metabolic dysfunction than a traditional LDL? Okay. Yeah. Which is fascinating. That makes a lot of sense because that's why I've liked to check it, is because I just feel like the traditional cholesterol to me is just not a great indicator anymore when we have all these other markers. But I wanted to kind of switch gears because our listeners always like to know what health experts do to keep themselves healthy. And so if you're comfortable, I wanted to kind of hear what a traditional week or a day looks like. What has been the most impactful in your health? Do you wear wearables? Are you doing anything crazy to get good sleep? Just walk us through what you do.
Probably 1,000 things a week. So number one, we're talking right now, I happen to be at a standing desk. I have a standing desk at home, standing desk at office. I have treadmill desks too. They're a little disruptive when I'm with patients, so I don't use them as often. Now, there just was an article published that sitting all day long promotes heart disease, but standing all day long doesn't prevent heart disease, but it didn't promote it. So it's still a mixed bag, but it's clearly a little bit better. That's just one sideline. I wake up about 3 dogs on my bed, so I'm never quite sure, about 5:30, 6 a.m. I take 5 minutes and I do some gratitude prayers and a little gratitude meditation before I touch my phone. You got to reach for your phone, but I try and wait 5 minutes and just set the tone of the day. That's every day. It's a little bit of a religious background to it, but then unfortunately, I do about 20 minutes of work just to clear some emails and not feel stressed about that. Did anybody overnight show up in an emergency room? I work out every day. I might get 20 minutes in, I'll grab it. I might get an hour in, I'll grab it because I have an active practice and I do go to the office 4 to 5 days a week, usually 4. But I'll do anything. I'm ADD when it comes to exercise. I might do a rebounder. I might do a treadmill. I might do an elliptical. I might do weight routine. I do a fair amount of barbells and all, not heavy weights, but I like to jump. I mean, there's just, I'll do anything that qualifies. Kettlebells in the summer, might be paddleboard. I live in a lake, so we try and grab our short Michigan summer and use it. I work, but I will I am a breakfast eater, but it's usually a little plant-based yogurt. I'm a big ground flaxseed guy, a couple berries. That'd be pretty typical. I love black coffee, organic, everything in the house is organic. I go to work with a lunch in a glass container. It's usually leftovers. My wife's a very, very good whole food plant-based. I'll call her a chef. I don't want to call her a cook. And I'm lucky that there's always something in the refrigerator. I don't snack much at work. I try to really limit it. Drinking water, after coffee, I'm over to green teas, black teas. There's so much data about tea and health, and I'm usually organic teas. I really try and do that. Nice whole food dinner when I get home, walk dogs, catch up on work. There's still a lot to work. I'm a supplement guy. I can't, beat Brian Johnson and Dave Asprey with 150 supplements a day. I probably take about 40 different supplements. I'm not a big fan right now of metformin, rapamycin, NAD supplements. Some people, are on them and feel great. I think the data's not in, but I'm I'm a big CoQ10 guy. I think everybody in the world should be taking CoQ10, probably the safest, most science-backed supplement in the world, but my vitamin D, my vitamin K2, and all the rest. Plant-based eaters struggle to get omega-3, so I eat my ground flaxseed, but I take some vegan omega-3. There's some nice now multivitamins just for vegans that have a lot of this in one-stop shopping. Makes it a little easier. Music, I mean, music lifts my spirits, and there's either Jelly Roll or Indian music or something going on all the time, quietly in the background, kind of keeps me sane. I'm trying to think of, community. I'm involved in the community. I mean, that's kind of a classic Blue Zone thing, is not to be lonely and be connected. But I've got, fortunately, kids, grandkids, wife, elderly mother, lots of things to stay socially connected with. And I'm just driven by what I do. I mean, I'm 65. I'll keep doing it, I hope, for another 20 years. It's getting more and more and more interesting, in my field, preventive cardiology, integrative cardiology. So I think we're just at the beginning. I feel like everything we've done now is just preparing us for the next best thing, because we still have heart attacks. We got a lot to do.
Every 33 seconds, right? I mean, it's still
Every 33 seconds, somebody dies, maybe every 25 seconds of cardiovascular disease, and it's still number one. So, get the blood test, get the calcium score, do a reality check on your lifestyle, see a doctor, see a dentist, do the right thing.
well, and one thing, a couple questions. One, is there a magic CoQ10 milligram? Like, is it 300 milligrams that's in the research? Because I've seen anywhere from 100 to 300.
The research is, the most impactful studies are 200 to 300 milligrams a day. It's a simple blood test at Quest and LabCorp. I base it on the blood test. And I have many patients taking 800 milligrams a day if they're dealing with hypertension, serious palpitations, or definitely if they're dealing with congestive heart failure. That few that are on 1,000 milligrams a day. It's about the most non-toxic vitamin on the planet.
Well, and then my second question is, what got you into supplements as a cardiologist? Like, was it just something you were passionate about? Is it?
My influence to go down this path was partly, I have a cousin who's an integrated family doc in town. And 15 years ago, he'd be talking about magnesium glycinate, magnesium taurate. And, I'd just scratch my head and say, so much stuff I don't know, and I know how to put a stent in, but you don't, And I went and did, I got certified and did all my training, and you can't get away. I take heat all the time. Supplements are just expensive urine. That's a common mantra. But my answer is, but you don't read the science. You're not reading about pycnogenol. You're not reading about green seaweed vascular supplements that have, published research. And yeah, there isn't the funding to do the same kind of lipoprotein A, 8,000 double-blind randomized studies. But the supplements I use over and over in patients have multiple studies in humans, randomized studies, and it's good enough for me. And they're all very safe and actually very inexpensive.
Yeah, I mean, you mentioned berberine. Like, we see huge results with berberine and bergamot. Do you do plant sterols as well? Is that one of the things you incorporate in?
I'm not a big fan of plant sterols. I have an odd view. There's no doubt that they fight cholesterol in the intestines, and they fight to get absorbed, so your cholesterol doesn't get absorbed, so your blood cholesterol might go down. But there's some animal data that because they are sterols, they get incorporated in your plaques. So you still got a sterol in your plaques. And in animal studies, they may actually be a little more toxic than even cholesterol. So there is no human study. There's so many other options to lower cholesterol. I just don't rush to plant sterols. So I have an odd view there.
Yeah. Well, and we love pre-lipid, but they do folic acid, which I keep trying to get them to switch over to methylfolate. Because we've seen huge drops. I mean, like even more than a statin with pre-lipid, which of course is red rice yeast, primarily. And then is there anything that you want to leave our listeners with? I feel like that you covered so much information, but we always talk about little by little, little becomes a lot. Is there one piece of advice that you want to leave our listeners when it comes to cardiovascular health?
Although I'd love to say something brilliant about lifestyle or broccoli sprouts, I'm a big fan of sprouting at home. I use the hashtag on social media all the time, test not guess. We get mammograms or MRIs of the breast and colonoscopy or Cologuard or total body MRIs. Nobody focuses on cardiovascular disease. All you got to do is get a good panel of blood work and at least get $100 coronary artery calcium scan. Don't think you couldn't be a heart disease member, even though you're playing pickleball 2 hours a day. I see people all the time, I mean, in their 40s, early 40s, that they've got massive amounts of coronary disease. And usually we can dig and find a reason. Sometimes you can't. Rare, very distressing when you can't. But, you know, face reality, get tested and prove you're normal, and then have a little happy party. But if you're not normal, get to somebody who knows how to deal with, you know, early silent atherosclerosis.
Is there an age with the CT calcium score that you're like, this is the
Yeah.
number that everybody should do it at, or does it depend on risk factors?
I do vary it by risk factors. I'm actually working with a team. There will be an app out maybe next year where you'll put in your numbers and based on very, very good scientific algorithms. I'm very rarely under 40, but 40 to 45 for a guy, 45 to 50 for a woman, unless there's exceptional risk factors. I don't like to order CT scans on premenopausal women, but 45 to 50, if there's, you know, cholesterol's at 290 and a family history, let's start with that. It's just accessible, available, and inexpensive.
It is. I mean, $100, it's worth it to detect disease. Well, thank you, Dr. Kahn, for being on here. This was wonderful. And I'm so happy for all of our Georgia listeners that you are licensed in Georgia and a resource for them too. And,
Happy to do it.
and I'll link to your book for the lipoprotein A, because I have not read it. I didn't know you wrote that book, so I will be reading it. So thank you for sharing that as well. And thank you so much for being on here.
It's been a total pleasure. Little by little, we're making a dent, aren't we?